This presentation is about the effect of warfarin on the brain. So here's my presentation outline, and here's my introduction. Warfarin is an anticoagulant, which is a blood thinner medication that helps prevent blood clots and strokes. It's the standard oral blood thinner for atrial fibrillation, which occurs when the heart beats in an irregular way. However, while it helps prevent these things, it increases the risk of intracerebral hemorrhage, which is the deadliest type of stroke according to the National Center of Biotechnology information. This can happen if warfarin makes the blood too thin, emphasized by the American Academy of Neurology. Atrial fibrillation is most common among the elderly, and with an aging population, warfarin-related ICH is expected to increase, as said by the American College of Cardiology. People who take warfarin usually have an INR level of 2.0 to 3.0, and those who don't take warfarin have an INR of 1.0. INR levels are calculated by an INR test, which measures the amount of time it takes for the blood to clot. This study is titled Experimental Model of Warfarin-Associated Intracerebral Hemorrhage. Its purpose was to characterize a mouse model of warfarin-associated ICH that can be used as a reliable basis for future studies on the clinical and pathophysiologic aspects of the disease. They were also looking to see the influence the level of warfarin has on hemorrhagic blood volume, hematoma size and enlargement, and neurologic outcome. CD1 mice aged 12 to 16 weeks were used. 46 of them were used to determine INR values at the start of and after warfarin administration. 99 of the mice were used to study hemorrhagic blood volume, hematoma size and enlargement, and neurologic outcome after ICH induction in both anticoagulated mice and non-anticoagulated mice. So mice with warfarin and mice with no warfarin, which is known as the control group. While the mice were under anesthesia, ICH was induced by injection of either 0.5 microliters of saline containing collagenase or just saline alone into the right striatum. The mice's hemorrhagic blood volume was measured by hemoglobin content determination. The mice's hematoma size was measured by computer-assisted outlining of brain slices after being humanely killed under deep anesthesia. The mice's neurologic outcome was assessed on a 5-point scale, where motion activity was recorded in order to see how the mice's brains were functioning after being induced with an ICH. Each of these were determined 2 and 24 hours after ICH induction. So as for the results of this study, the INR in mice with no warfarin was 0.8 plus or minus 0.1, which is a normal range for those who don't take a blood thinning medication. Meanwhile, in mice that had warfarin in them for 24 hours, INR values increased to 3.5 plus or minus 0.9. In mice that had warfarin in them for 30 hours, INR values increased to 7.2 plus or minus 3.4. Compared to mice with no warfarin, mean hemorrhagic blood volume was 2.5-fold larger in mice with 24 hours of warfarin and 3.1-fold larger in mice with 30 hours of warfarin in them. Mice with no warfarin in them had a 0% chance of mortality, while mice that had warfarin in them for 24 hours had a 10% chance of mortality, and mice that had warfarin in them for 30 hours had a 30% chance of mortality. Regarding hematoma enlargement, mice with no warfarin was negative 1.4%. Mice with 24 hours of warfarin was 22.9%, and mice with 30 hours of warfarin in them was 62.2%. So as you can see from these results, this tells us that warfarin increases the mice's INR values, mortality rate, blood volume, and hematoma enlargement. So here's a picture that shows the representative brain slices after saline administration and collagenase administration. As you can see on the left, the saline didn't cause relevant ICH bleeding. C indicates control mice with no warfarin pretreatment, while W24 and W30 indicates mice with 24 hours and 30 hours of warfarin pretreatment. So as shown on the right, you can see how as the hours got longer, 24 hours of warfarin and then 30 hours of warfarin, the hematoma became much more dense. So in conclusion, as proved by the results of the experiment, the intensity of warfarin-associated ICH affects blood volume, hematoma size, mortality, and neurologic outcome. And with these findings, mice models of a warfarin-associated ICH can be used as a reliable basis for future studies on the clinical and pathophysiologic aspects of the disease, and also for preclinical testing of new therapeutic approaches. This study is called the Effect of Warfarin and Intensity of Anticoagulation on Outcome of Intracerebral Hemorrhage. Its purpose was to study the determinants of ICH outcome to quantify the independent effect of warfarin. This study categorized 435 patients with ICH aged 55 years and older into two groups: those who went directly to Mass General Hospital's emergency department and those who were transferred to it after being evaluated at another hospital. Patients' ICH was located by computed tomographic scans of the brain and were classified as lobar or deep hemispheric. Clinical characteristics were obtained through an interview with all subjects or their family members. Hemorrhages were categorized as warfarin related if warfarin was reported as a regularly ingested medication, and the intensity of the anticoagulant was recorded as the international normalized ratio. Independent predictors of 3-month mortality were determined using the multiple logistic regression analysis, which allowed researchers to see association between the patient characteristics and mortality, and the functional outcome among survivors of ICH were determined using the 3-month Glasgow scale. Among the entire study was a 31.7% rate of 3-month mortality. More specifically, patients not taking warfarin had a 25.8% rate of 3-month mortality, and patients taking warfarin had a 52% rate of 3-month mortality. The mean age among patients in this study was 74.4 plus or minus 9.3 years old. Significant predictors of death was, of course, use of warfarin, age, and presence of diabetes mellitus. Patients over 70 years old had a 19.7% rate of 3-month mortality versus people 70 or younger with a 37.9% rate of 3-month mortality. Patients with diabetes mellitus had a 44.3% rate of 3-month mortality, and patients without it had a 29.2% rate of 3-month mortality. Whether patients had deep hemispheric or lobar ICH, were male or female, or took an antiplatelet agent, did not have an effect on mortality. Regarding functional outcome, only age predicted poor clinical outcome among patients, which had a GOS score less than 4. And the main reason why patients used warfarin was for atrial fibrillation, which accounted for 49.5% of patients within the study. So this is the table that shows the association between patient characteristics and their mortality rate. And as you can see, the characteristics with the biggest difference of mortality rate were age, presence of diabetes mellitus, and warfarin use, compared with the other characteristics that do not have as much of a difference in the risk of percent of mortality. This is the Glasgow scale that represents the functional outcome among survivors of ICH at 3 months. So for patients with lobar ICH that didn't take warfarin, 28.6% of them died, 40.7% of them had severe disability, 12.3% of them had moderate disability, and 18.4% of them recovered normal premorbid activities. For patients with lobar ICH that did take warfarin, 57.6% of them died, 23.7% of them had severe disability, 10.2% of them had moderate disability, and 8.5% of them recovered premorbid activities. Now for patients with deep hemispheric ICH that didn't take warfarin, 22.5% of them died, 45.3% of them had severe disability, 21.2% of them had moderate disability, and 11% of them recovered normal premorbid activities. For patients with deep hemispheric ICH that did take warfarin, 44.2% of them died, 41.8% of them had severe disability, 7% of them had moderate disability, and 7% of patients recovered normal premorbid activities. So an important implication of the data is that the outcome from lobar ICH appears to be no better than that associated with deep hemispheric ICH. The results of this study concluded that warfarin use does in fact increase the risk of death from its cause of ICH, because patients taking warfarin had double the rate of intracerebral hemorrhage mortality when taking the anticoagulant regularly. As mentioned earlier, those not taking warfarin only had a 25.8% rate, and those taking it had a 52% rate. Based on the data, the intensity of anticoagulation independently predicts a 3-month mortality for those who have a warfarin-associated ICH, as the risk of fatal outcome increases when a patient's INR level increases. Both studies concluded that the anticoagulant warfarin increases the risk of mortality from intracerebral hemorrhage. They also concluded that the intensity of the medication affects the functional outcome of the patient, just like how in the first study, warfarin affected the mice's physical abilities, and in the second study, warfarin affected the patient's physical abilities. Discussion and next steps. The second study contained a limitation, as the functional outcome of patients may have been underestimated as a result of lost contact with them after discharge from the hospital. So, future studies similar to this should only contain information on patients who are followed up after discharge, so functional outcome statistics are accurate. Regarding the first study, the administration of collagenase to induce an ICH in a subject who was already treated with warfarin disrupts the true effect of warfarin, and deliberately inducing an ICH doesn't compare to the true development of an ICH that naturally develops from warfarin itself. So, future studies should only focus on a subject with only warfarin in their system, so we can have a clear understanding of how warfarin alone causes an ICH. It was mentioned in the second study that careful control of the INR may reduce not only the risk of developing an ICH, but also the mortality of it, which supports the possibility that rapid reversal of warfarin effect may improve the bad outcome of warfarin-associated ICH. It was also mentioned in the first study that the time window of ongoing bleeding is prolonged in warfarin-associated ICH, which means that there's possible opportunity for hemostatic treatment to stop further hematoma growth. And that is the end. And here are my references.